Morning, everybody, for Rush Nephrology Renal Biopsy Conference for September 12th, 2024. We don't have a CME code today. This conference has usually been recorded. We post them all on our YouTube channel. Look for it under Rush Renal Biopsy Conference. We're getting close to 100. And they're organized by the topic too. If you're interested in a specific type of renal lesion, you can look it up there. As usual, we have nothing to disclose about our case, and we also protect patient confidentiality by changing certain things within the case study. Today we got a really fun case. You know, I tweeted out, I said, has a lot of red herrings or not red herrings, and there's a lot of information in a broad differential diagnosis, which will be fun to discuss. And it'll be fun to work through the pathology as well, because it's not an easy decision on what is actually going on when you look at both the serology and the pathology. So I'm looking forward to a lot of fun. I guess we have Dr. Gashti is going to start the case. Casey, you on?
Yeah, give it 1 second. I'm going to unmute his mic, and then he will start. And welcome to our applicants. We're excited to have you stay on after the end. We won't call on you.
I'd like to welcome, if he's still here, a special visitor, Dr. David Goldfarb, who's a stone master, but he's a self-admitted tubule guy. He's not a glomerular guy. So, David, if you're on, welcome. It's good to see you. Maybe we can teach you something about the important part of the nephron. And I just wanted to point out that we are going to catch your Mets before the season's over. Casey, you want to take over?
Yes. Okay, our case is an 80-year-old female. She has a history of B-cell lymphoma about 7 years ago. She received treatment with rituximab and achieved remission and has been in remission for the past few years. She has breast cancer that was diagnosed about 7 years ago. She had a mastectomy, and that was presumably curative. She has been carrying a diagnosis of smoldering multiple myeloma, and this was based on initial presentation of thrombocytopenia, founding IgG lambda monoclonal protein in her serum and urine, and a bone marrow biopsy that showed 10% plasma cells. She also has biopsy-proven pulmonary sarcoidosis, hypertension, heart failure, and a couple of different strokes. She had a ischemic stroke 10 years ago, and she had a subdural hematoma 2 years ago. And those have left her with some degree of dementia, vascular dementia. So she comes to our emergency room with sudden onset of bilateral upper and lower extremity edema. These were relatively new findings for her, and they have been lasting for about a few days. She denies taking any NSAIDs. There have been no recent changes in her medications. Her family reports that she's been more confused recently. And upon checking her initial labs, it was noted that her creatinine was elevated to 6 milligrams per deciliter. Of note, her creatinine was normal at 1 about 5 months ago, and it was 2.5 about a month prior to admission. Her urine had 1 plus protein, 3 plus blood, greater than 182 RBCs, and 40 WBCs. Nephrology was consulted and ordered additional serologic workup, which showed significantly abnormal ANA with a titer of 1280. Anti-double-stranded DNA of 95, anti-Smith, SSA, SSB, all elevated, and her complements were low, C3 of 20 and C4 of 3.5. She had an admission 5 months prior to this current presentation with that acute thrombocytopenia. Her platelet count were 14, and during that, so she presented to hematology, and that's when they checked her labs, and her platelet was 14,000, and so they admitted her for further workup. And so these serologies that I'm mentioning had been repeated 5 months prior, and her ANA was positive, but a much lower titer. Anti-double-stranded DNA was pretty much normal at 5, and her complements were normal. So these labs are from 5 months ago, and now these labs are abnormal. She underwent a bone marrow biopsy and axillary lymph node biopsies. Bone marrow showed lambda-positive plasma cells consistent with a smoldering multiple myeloma. Her lymph node biopsy did not show any evidence of lymphoma. So they called her thrombocytopenia ITP. They gave her some platelets and some IVIG, and that improved her platelets up to 164,000 prior to her discharge. Again, this is from the admission 5 months ago. At the current admission, her platelets are 114,000. During the prior admission, her creatinine was normal, and her urinalysis was completely bland. In addition to nephrology, rheumatology, and hematology were also consulted to address the findings of abnormal serologies as well as her hematological findings. So past medical history, she has a B-cell lymphoma, smoldering multiple myeloma, pulmonary sarcoidosis, hypertension, hyperlipidemia, dementia, subdural, CVA, heart failure with preserved ejection fraction, and breast cancer. Past surgical history, lung biopsy, lymph node biopsy, bone marrow biopsy, breast biopsy, and a mastectomy. She never smoked, no alcohol or illicit drugs. She has no family history of kidney disease. Her siblings have the usual hypertension, diabetes, and a variety of other cancers, but nothing that was really contributory to her current presentation. She did not have any drug allergies. Her meds, amlodipine, hydrochlorothiazide, lisinopril, metoprolol for hypertension, atorvastatin for cholesterol, and letrozole as part of her cancer treatment, breast cancer. Her vitals, blood pressure was 132/60, heart rate of 66, respiratory rate of 14, temp of 97, and she weighed 73 kilos, 160 pounds with a BMI of 31. In general, she was pretty lethargic. She would wake up to stimulation. She was oriented to about oriented times 1, maybe 2 at times. Lungs had a dry left basal arrols. Cardiovascular was normal, no murmurs. Abdomen was benign. She did not have a skin rash. She had some bruising over her arms and legs, but nothing that would sort of be specific. She had 2+ bilateral lower extremity edema, and her upper extremities were also edematous, but not necessarily pitting. So here are some labs. Sodium 136, potassium 4.5, chloride 108, bicarb 18, BUN and creatinine were 105 and 5.7, glucose of 93, total protein 6.5, albumin of 2, calcium adjusted 9.6, total bili 0.3, and her liver function tests were normal. White blood cell count was low at 2.2, hemoglobin of 8.2, platelet count of 96,000, MCV of 88. As mentioned before, her ANA was positive. Her anti-double-stranded DNA was elevated. SSA and SSB were both elevated. Anti-Smith was elevated. Anti-RMP was elevated. C3 was low at 19. C4 at 3.7. Anti-histone was 4.4. Her ANCA, anti-GBM, and rheumatoid factor were all negative, and her cryo was negative. Quantitative immunoglobulins showed a normal IgG, IgA, and IgM level. Her beta-2 microglobulin, which has been checked on a frequent basis due to her smoldering myeloma history, was elevated at 33, and this is similar to her prior labs. This is not higher or lower. Her SBEP and immunofixation showed a monoclonal IgG lambda, the concentration of 0.6 grams per deciliter. Her urine also had a monoclonal IgG lambda, and her immunoelectrophoresis showed 42% of her urine protein was albumin. Her kappa was 18, lambda was 25, with a kappa lambda ratio of 0.75. Urinalysis showed a specific gravity of 1010, pH of 6.5. She had 1+ protein, 3+ blood, no glucose, bili, or ketones, more than 180 RBCs and 40 WBCs, no bacteria, no crystals, and her urine protein to creatinine ratio was 960 milligrams per gram.
So we're going to start with a poll here. I want to know what people think about what you think the patient has. We've got 4 options. Anybody that's not a co-host can vote. Option 1 is what you think this patient has: a paraproteinemia related to renal disease. This could be PGN-MID or it could be cast nephropathy. In other words, this smoldering myeloma is more than smoldering myeloma. Number 2 is an immune complex GN. Number 3 is post-immune crescentic GN. Number 4 is the possibility of having both, a paraproteinemia, perhaps cast nephropathy with an immune complex disease, GN, or some version of 1 and 2 together. Please vote. We don't know what you're voting. We'd like to get a good representation.
I don't believe there's a question. I don't think we had the ACR ratio, correct, Casey?
No, but she had 950 milligrams of total protein, and based on the urine electrophoresis, she had 40% albumin, so it would be about 400
Yeah.
milligrams.
Yeah.
People that know me know that I like polls when that are not obvious, that there's no mandated decision or mandated answer. That's kind of the whole role of this conference, is to create a discussion that's not obvious, and that none of our cases are obvious. And I think the poll results are going to kind of show that. If you want to, we could probably put them up now.
Hey, Roger,
Yeah, Dick.
what about none of the above?
What about what?
What about none of the above?
Oh, okay. Well, let me ask you, Dick. Then, what is your none of the above?
Because there's a lot of disparities in the history and the laboratory data that trouble me a lot.
Well, we'll get that. That's a really good point. And I didn't. There's a very, very long differential that I didn't want to put everything in there. So when I have it discussed, if they're not brought out, we'll bring you back in to bring that up. What your thoughts are. Right now, we've got both 1 and 2 is the winner. Interesting. I like that. Bill told me about a case. Bill Whittier told me about a case in New England Journal of Medicine this week that was a combination of lupus and a amyloid from inflammation. I thought that was really cool. So, I think that's kind of in the differential here. Who says you can't have two things? The second is an immune complex disease. The third is a paraprotein-related disease by itself, and the fourth is a pauciimmune crescentic GN. So I want to hand it over first to Bill and see what Bill thinks about these options and all the options. See if you can guess everything, including what Dr. Classic is going to pull out of his hat, which he always manages to do.
Thanks for giving me such an easy case. But this is real life, and it's pretty exciting. I'd love to have been on rounds to hear Dr. Gashti discuss it too when he first heard the case. The initial presentation to me seemed like one that was going to be sudden onset of edema and with nephrotic syndrome. And I thought that was going to be it. It was going to be a nephrotic syndrome and some sort of podocytopathy, and there was renal failure along with it. And I was kind of waiting for the proteinuria to be 20 grams and the albumin to be 1. And then you get down to the urinalysis and the urine protein creatinine ratio, and you find out it's less than a gram. And it could be that she had nephrotic syndrome before, and now she has renal failure, and so she's not excreting as much protein or albumin. But if you're really going to believe this urinalysis specimen, then the cause of her edema is something other than nephrotic syndrome, right? Because she really doesn't have nephrotic syndrome by the definition. We've only got 960 milligrams of proteinuria. So then I'm trying to think about my AKIs with a little bit of proteinuria, active urine sediment, and a lot of edema. That's that kind of a syndrome. And that's usually when I think about, it could be a RPGN. Certainly lupus would be in that category, significant lupus nephritis with crescents. I think that's kind of high up in there because of her serology that's positive. The other one where you have a lot of edema out of proportion to the proteinuria, which is kind of where I'm going with my discussion. I think about a post-infectious or post-infectious related GN, but there's nothing really to suggest that here. She doesn't have an active infection, but she does have significant hypocomplementemia. And then there's all the other diseases that she has that we have to consider of associations. Sarcoid could be significant interstitial nephritis or even a membranous. Myeloma is, just so many things to cover in myeloma. Could it be a membranous? She had breast cancer from a while ago. She also has sarcoidosis. We don't have a PLA2R, if I remember, but I wouldn't really expect membranous to come in with such significant AKI either. So these are kind of a little bit less likely on my differential. And I probably would move lupus up about as high as I could in my differential. And so in that, we have lupus that can be pauciimmune, right, with just background mesangial, or we can have lupus that can be immune complex mediated with subendothelial deposits. And given the severity of the hypocomplementemia here, I'd probably lean a little bit towards number 2 in the poll, and just kind of ignore the lambda because it could be involved, but it also could not be involved. So I'm just going to, as a purist, stick to maybe an immune complex mediated GN, because that seems to put everything together the best way for my mind.
Great. Dr. Rajasekaran, what do you think's going on?
Well, thank you, Roger, for having me. Just a couple of questions. Casey, excellent presentation. What was the race of the patient? And other questions I had was, do we have a PTT, a PT, PTT, INR, and antiphospholipid workup? And if there was an ADAM TS13 by any chance? And also, I know that the indirect immunofluorescence for the anchors were negative, but did we have like a PR3 and an MPO?
Yes, thanks everyone. So the patient's African American. Her ADAM TS13 was checked during that admission 5 months ago when she presented with a platelet count of 14,000. That was negative. Her coags currently are normal. She has had an antiphospholipid hypercoagulable workup in the past when she was seen 5 months ago when the lupus serologies were slightly positive with ANA positivity but at the time double-strand DNA and complements were normal. So she had, with this thrombocytopenia, she had all of that workup and those were all negative. And what was the last one you asked?
The PR3 and MPO.
Yes, they were checked as part of the ANCA process. We ordered the ANCA screen, which was negative, but we also did MPO and PR3, they were negative, normal.
Thank you. From the look of the labs, I think that she's got severe classical pathway activation. So this points towards more of a lupus or a lupus overlap. She's also got sarcoid. I'm expecting something very proliferative, immune complex based on the biopsy. But the level of proteinuria is not as much. That's one thing, but it can certainly happen. Another possibility I was also considering was about having a concomitant MGRS lesion that's going on. We know that PGNMID actually can cause low C3 levels, typically doesn't cause low C4 levels. It does activate the classical pathway, but it's more common with IgG3 kappa, but not to say that IgG lambda can't happen with the PGNMID. So if everything put together, I'm suspecting more of a immune complex mediated lupus-like presentation, proliferative class 3 or 4 with an MGRS component and particularly PGNMID. She's not on any medications that would explain the antihistone because we were looking for hydralazine. I think everyone was looking for hydralazine, but that's not there unless she's taking something else over the counter or she's taking hydralazine for HFpEF and we're just not aware of it.
Yeah, we probed her quite a bit about that. No hydralazine in the picture. You know, she's on that letrozole for her breast cancer, and there were some cases of drug-induced lupus with that. There was like a few case presentation with only skin. I've never seen anything with that drug with regards to systemic being reported.
Thank you. A little less likely for it to be an ANCA negative posse immune in this case, just because of the classical pathway activation so much. And rheumatoid factor is actually an indirect marker for ANCAs. So even if the rheumatoid factor is completely low, so I will put that there is posse immune is very low on this in addition to whatever is going on.
You find rheumatoid factor is often up in ANCA vasculitis?
That was actually being used a long time back before we even had the PR3 and MPO, before we had the ELISA-based assays. When they were only dealing with indirect immunofluorescence, they used to follow rheumatoid factor as an indirect marker.
Interesting. I thought we were following it in the past for an indirect marker of cryoglobulins.
Cryo as well, but even ANCAs way back.
If you find some literature on that, because I think that at least us Rush people, that's not something we've done. Throw a reference in there if you get a chance, because that's new to me, and I don't deny it for a second, but it's just new. I'd love to see a reference on that. I like Steve said, I also call it a poor man's or fast rheumatoid fast cryo, because cryos take forever, and if the rheumatoid factor is negative, we're pretty assuming it's a type 2 and a type 3 cryo.
Roger?
Arun, one more second, Dick. Arun, what's your number one choice?
immune complex, GN.
Okay, Dick, go ahead, take it away.
Well, your panel or your poll now, it's strictly an Occam's, Reverend Occam's type of a poll, whereas I think the proper poll would have been a Hickham's dictum poll in which the patient is entitled to having multiple diseases.
Well, I did give you a,
She already has sarcoidosis and lupus. Why can't she have a third disease? Or even, and she has smoldering myeloma. She has 3 diseases already. Why can't she have a 4th? The thing that troubles me most about this case is sudden onset of edema in the lower and upper extremities, non-pitting in the upper extremities, a serum albumin of 2, and very little proteinuria. This is not nephrotic edema. I mean, almost unequivocally, this is not nephrotic edema. Therefore, we have to look for non-nephrotic causes of massive systemic fluid accumulation, and I wonder whether this is a systemic capillary leak syndrome, a Clarkson syndrome, which has been seen in patients with monoclonal gammopathy, which would mean that there is really no, I mean, she may have lupus, but it isn't explaining everything that the patient presents with. I'll give you lupus nephritis, but there's something else going on here that we don't completely understand. And I think that this may be a systemic capillary leak syndrome. Furthermore, a platelet count of 14,000 is not part of regular lupus nephritis. You can get thrombocytopenia, not 14. That's in the TTP range. Now, the patient doesn't have any neurological manifestations, and we don't know whether she has a hemolytic anemia because we don't have a Coombs test, we don't have an LDH, we don't have a haptoglobin, we don't have a peripheral smear. So I think that nothing on the list of the 4 Occam's razor choices are going to be the correct one.
So you're not going to come, I mean, the permutation of 4 things is, I don't know, whatever, is 16, 4 cubed. I don't know what there's some math to tell me that permutations, and I'm not going to ask you which one, but you think we're missing it somehow, that there may be likely to be several things.
Yep.
Okay.
But I think that's a really, I mean, that's kind of in a way how I was approaching it too. It's this marked, striking difference between what looks, at least in the beginning, to sound like nephrotic syndrome, and then there's not a lot of proteinuria. And that's kind of why I was bringing up something else a little bit separate too, like a post-infectious, you know, or you know, something. Even endotheliosis can present that way.
Maybe she's just sick. And it's
Yeah,
a negative
serum
acute phase
albumin,
reactant.
that's right.
She's shut down. She's taking in salt and water, and she's becoming overloaded. I mean, she's edematous. I mean, for me, I'm reading this and I know I'm kind of simple on all this stuff. And I like Occam's razor. That was always Mel's favorite term. And I kind of like it as well. Hickham's dictum, kind of an interesting term, but I mean, to me, this smelled like lupus all along. I know she has all these other things going on, but you know, ITP can actually precede lupus, not commonly, but it can occur. And now she's got a pancytopenia, all this serologic abnormalities. I think the paraproteinemia is a red herring. If we really thought she had sarcoid as a cause for her renal disease, I assume she had pulmonary limited sarcoid. It's funny that unless I missed it, I was trying to read it here. I don't even see an ACE level given, and I figured somebody would have sent that off. Not that it's the best way to look at it, but you would expect if she had active sarcoid, that would be elevated. I'm not going to rediscuss everything everyone discussed, but I think this one is going to have severe lupus nephritis with membranous and proliferative changes.
Dr. Reen had texted, I think it just came to me, but why could this not be endocarditis? I think, you know, we always have to be careful to never exclude endocarditis, especially in an older individual. Hypocomplementemia, I don't know if I saw rheumatoid factor getting along those lines, but it was low. Yeah, it was low. I know that's not 100%. I know that was.
And the cryo's negative.
And that was one of Dr. Lewis's favorite. You know, cryos aren't always positive in obviously, you know that, Steve, but I didn't mean
No, I know, but the two together, I'm just saying the rheumatoid's negative.
But I think it's a really good point. I mean, you know, we never ever want to miss endocarditis as a cause of an RPGN like picture, especially in somebody older, because you hit them with immunosuppression and you'll kill them. So I think that's a really good point. Let's move it along. Let's see what the next slide is. I think there's a little more information. Casey, you want to read it?
Yeah, so the PAN consultation occurred, and rheumatology said this is very much presenting like a drug-induced lupus. Because they didn't think that because of the patient's age and the fact that she had multiple antibodies that were positive, specifically anti-Smith and anti-histone, that they were more worried about a drug-induced, but where is the drug? They couldn't find the drug. So that was interesting. So they said, it should involve the skin, less common for nephritis. We don't know. So they said, okay, why don't we just start her on some steroids empirically while we can get a tissue so for further diagnosis. So they said, start prednisone. We think this is drug-induced lupus. Do a kidney biopsy. Hematology reran the tests. They said that the kappa-lambda ratio is stable. They did a skeletal survey. There was nothing there. They said, if you're really worried about a paraprotein-related kidney lesion, do a kidney biopsy. We don't think this is myeloma, but if this is MGRS, the only way to look at it is the biopsy. So that's essentially what we ended up doing. We first started the patient on dialysis because we wanted to make sure that she can tolerate the azotemic load of the steroids. So steroids was started, dialysis was started. We wanted to optimize her for the biopsy procedure. So the patient was started on dialysis, was started on steroids. And this was, it's not as simple as what I'm sort of explaining. We had this period where the patient didn't want to do anything and then we were like, she's not decisional, and then we had to pull the family in. So that whole thing took about 3 or 4 days before one of the family members said you should go ahead and do the biopsy. And so that's what happened.
So
Roger,
I heard some groans from you, Dick. So
I hate to be hypercritical, but these 2 consults were remarkably unhelpful.
Yes, I agree.
Usually it's just cardiology that's unhelpful. So
Yeah.
I see some other people doing it too.
I gotta tell you, I'll defend rheumatology at Rush. They're usually extremely helpful, but I don't know about 30 of prednisone. It's either like, either give, it's like Ed Lewis said, you either give steroids or you don't give steroids. You don't, are you a real nephrologist or real, and 30 is not enough. So I don't know. That's kind of an interesting cutting in the middle.
I mean, hematology.
Granted, that might work for drug. That might be okay for drug-induced lupus, but this is if this is lupus in the kidney, it's an RPGN. It's pretty bad. So.
Hematology has known this patient for many years through her years of lymphoma and then her years of smoldering myeloma and then her thrombocytopenia presentation. And they basically said nothing that we see here except the acute renal failure and the lupus serologies are new, and those are not hematological. So they didn't feel strongly that this was a primary hematological issue.
Bill, does this information change your approach in any way?
No, I mean, in a way, I agree. She needs a kidney biopsy, so that's fine. But yeah, and I would have done empiric a little bit higher dose steroids, even though she was so azotemic, and same thing, dialysis to make sure to help control that while we're kind of waiting for a more definitive answer. And oftentimes, the kidney biopsy can give the whole answer to the entire picture. Hopefully, it does in this case.
All right. Well, then I think it's time for the kidney biopsy. So let's get the wheel going here. And see who gets to read it.
It lands on Bobna. I promise it's not rigged.
You just had an old biopsy.
I know. I gotta update that. The joke was it would never land on Bobna, and so we just made it all Bobna one day.
Yeah, we did. That was mean, but she's a good sport. Want to put the wheel up?
Yep.
I'm not seeing it up if that's the case.
Hold on 1 second. What happened there? Oh, it was pinned. There we go.
All right. Oh, great wheel. Tell us who reads the biopsy. For those of you that don't know the wheel, it's the fellows and the faculty. The fellows have a two chance, and the faculty has a one chance. And sure enough, it's picked our fellow Michael, superstar Michael.
All right. Give me a second here, Michael. You are in the fellow's office. Close. Test it out. Can we hear you?
Testing, testing.
Okay, good. I'm going to give you control here in a second. And then it's all yours. Give me here.
Right.
Click. All right.
Okay. So we've got trichrome stain, one core. You can see several glomeruli here. It doesn't look like there's that much fibrosis. I would say like 15 to 20%.
Yeah, I agree with that, Michael. Yeah, it's pretty well preserved.
Cool. Okay, H&E stain. We have a glomerulus here, and it does look like there's a lot of mesangial expansion. With hypercellularity, it looks like there are more than 3 inflammatory cells here between capillary. And the capillaries do look kind of closed in many areas here. Some are open. I don't see any areas of necrosis or like crescentic lesions.
Yeah, and if you go just to the right, look at that capillary wall up a little bit. Yeah, look how thickened that one is. That down. Yeah, that one there.
Yeah, this is a pretty thick GBM. Yeah. Okay.
Is there a little more pinkish hue at 9 o'clock, David, or am I overreading that? All the way over to yeah, there?
I think that's mesangial.
Okay.
Yeah.
Another H&E stain, and this glomerulus kind of has like a lobular appearance a little bit.
Yeah.
Which is how it's cut. And I do see mesangial expansion here too. And it actually looks like the GBM, the capillary wall is thickened here too.
Yeah, there's one right in the center that, yeah, right there. Yeah, look how markedly thickened that one is throughout.
Yeah, and hypercellularity here as well. And yeah, like no crescentic lesions here from what I can see.
Okay.
Okay. This looks like fibrinoid necrosis to me.
Yeah, a big segmental necrotizing lesion.
Yeah. And then you have again like mesangial expansion and glomerular basement membrane thickening, some hypercellularity. Is there a little bit of interstitial nephritis going on here too?
Yes. Yep.
Cool.
Looks like lymphoplasmacytic infiltrate.
Yeah.
Hey, Michael, can you just describe what the factors you see in that lesion that would describe it as segmental necrosis, fibrinoid necrosis?
I mean, the dark pinkish hue tells me that it's a fibrinoid necrosis. And then it looks like this is kind of, this area here is more just, I don't know, kind of collapse in a way.
Well, it certainly is any capillary architecture. I guess the other thing I was getting at, I don't know if David, is this charactic debris in the middle?
Yeah, I see some red cell fragments there. And yeah, a little bit of charactic debris and some epithelial proliferation. Yep.
But
Yeah, right there. Yep.
but
Yeah.
the fibrinoid is the lighter pink stuff, right?
Yeah.
And the redder stuff is probably the red cells.
Yeah.
Yeah.
Okay. Another H&E stain, and this glomerulus, again, I mean, it's not a scientific word, but it looks kind of wonky. I don't know if it was cut in a certain way, but very lobular appearing. But the basement membrane looks thickened again, and mesangial expansion again, and more hypercellularity. These are red blood cells. These aren't casts, are they?
Yeah, that might be procedural because I don't think they're like in a space there in a tubule.
Okay.
But I want to point out, look around 3 o'clock. Yeah, you can see all types of kind of chunky deposits, and they're involving the capillary wall as well. Yeah.
Okay.
This is that same glomerulus. So yeah, you could see that area, how it highlights really markedly thick capillary walls. Yeah. In the setting of lupus, we would call these wire loops.
Yeah, with that like thickened GBM.
Yeah.
Yeah, okay. And this is the silver stain. And I mean, to me, this looks like there are like breaks here.
Well, so yeah, look at the GBM, because in the mesangial area, it looks kind of moth-eaten.
Yeah,
But look at the GBM in the middle. Go straight down. Just keep going. Yeah, what do you think about that one right there?
this kind of looks like tram tracking to me.
Yeah, it's a double contour.
Um,
And then same over around 3 o'clock. Yeah, there's some double contouring. Yep.
yeah, okay.
But no spikes or holes.
So are this like moth-eaten appearance of it? These are not holes.
No, because that's in the mesangial area. We want to look at the GBM on the silver stain.
I see it. Okay.
Uh,
Is it
There is no evidence of capillary wall disruption that I've seen so far, right?
No.
No capillary wall disruption.
Oh, not on that one. I mean, if we had the silver stain on that one with necrosis, we would have seen rupture. But no, there was not a necrotizing lesion in this one.
This is an H&E stain. Is this a red blood cell cast or?
Yes.
Okay. Otherwise I don't see sloughing very much of it, at least not very much ATN, or interstitial nephritis here either. Okay, and then this immunofluorescence, it's clearly IgG positive in the GBM and in the mesangium too.
Yeah.
Well,
Also extraglomerular. Look at the tubules and interstitium up in the top left.
Oh
Yeah.
yeah,
Yep.
it's everywhere. Okay.
yeah, I don't know, why would you call this unequivocally positive? Look at the intensity of the IF and the interstitium compared to the glomerulus. I don't know, this isn't very impressive to me.
No, yeah, this is this is strongly positive. I mean, pretty much the whole thing is positive. So there's not much negative staining.
So what's this label in the right corner then?
Oh yeah, so this is the IgG, and then it was not full house. The IgA was negative. The M was trace.
I'm
It's
sorry,
really
you know,
confused.
that's
So
my
the
bad.
IgG is mislabeled here then.
Yeah, that's my bad. I'm sorry. It should be IgA negative.
Okay.
Sorry.
It left.
And C1q negative?
Yep.
Interesting.
Yeah, well, because if this is classical pathway activation and no CQ,
Yeah.
this is, I'm not impressed.
Well, we'll have to see. We'll have to see what the EM show.
I mean, it does look like a lot of background staining as well. That's why it's kind of hard to tell.
Let's move along.
Go ahead and click. Oh, there we go.
Okay, so both kappa and lambda are positive. It looks like lambda's a little bit brighter in density.
Yep.
And this is EM. So this is the blood space, this is the urine space.
So
And
this is why the fluorescence looks like it does, chock full of deposits throughout the entire glomerulus.
yeah, these are all deposits here, right?
Yeah.
Yep.
Okay.
Mesangial, subendothelial.
Yeah. And some podocytopathy too, it looks like.
Yep.
Again, yeah, a lot of deposits here in the mesangium and subendothelium.
Yeah, look at that one there to the left a little bit. Yeah.
Yeah.
Huge circumferential subendothelial deposits.
Yeah. And then
So those
here,
correspond to the wire loops, right?
Yep.
this is kind of the tram tracking appearance we saw, right, on the silver stain, like where the GBM is kind
Well,
of.
I think that's a mesangial area there,
Oh.
but look, you have the capillary lumen there, and you have the endothelium lining the lumen. What do you see in the endothelium? Yeah, to the right a little bit. Yeah, what do you see? What's that?
These are deposits, right? Subendothelial deposits, no? Oh,
No,
oh, wait, are these reticular bodies?
Yeah, TRIs, tubular reticular inclusions.
Okay.
Yep.
Mhm.
Good,
Okay,
Michael.
thanks. Okay, so this is clearly a proliferative immune complex lesion. It had subendothelial deposits, tram tracking appearance, so kind of MPGN appearance, and then you had the positive IgG lambda and IgG kappa, so it has that paraproteinemia aspect of it.
No. So they were both present. So there wasn't evidence of paraprotein related kidney disease.
Okay.
Yeah. No,
So,
it was not PGIMD.
next slide. Let's go ahead. I have a poll on that, I think. Yeah, so that's what we're kind of getting along to here. Which statement do you most agree with? The biopsy stain for both kappa and lambda. This is not a monoclonal. Certainly, there was no cast nephropathy, but what's left here is still with an MPGN picture. You always wonder about PGN MID. And the biopsy stain for both kappa and lambda. This is not a monoclonal related GN. Or the biopsy showed lambda a lot more than kappa. The paraffin block should be sent for pronase digestion. Looking for a better evidence of light chain restriction. In other words, an MGRS has not been ruled out. And you all know my famous quote that when in question, pronase digestion. I'm trying to make that on the go on the Statue of Liberty, but it's so far hasn't caught on. It's not viral yet, but I'm working on it.
Gotta get on TikTok.
TikTok, that's what of course, I'm too old to know where to where to go viral.
The other point, Roger, I'm not sure that I'm completely accurate, but this patient has a wide disparity between EM deposits and deposits by IF. So you have to ask the question, is this also a concealed monoclonal IgG deposition disease?
So in other words, masked.
Masked
Yeah,
or concealed.
Yeah, that's
because the absence of C1q in a biopsy that looks like this makes me very suspicious that this ain't simple lupus nephritis.
Yeah, well, I think that is the point. And I mean, when I look at this, I say, David thought the lambda was a lot more than kappa. It is, but it wasn't anything. When I'm used to light chain restriction, I'm used to one is light and one is black, and there's nothing in the middle. Yet this is a funny story, and like you said, Dick, maybe there's something masked. Now, typically masked deposits is when you don't see anything, and then you do pronase digestion on the paraffin block, and one of them comes out, either lambda or kappa. In this case, we would expect lambda to come out because that's the monoclonal protein in the blood and urine. What about masking to the point where you see both? And I went back and looked at the article. It says the role of pronase digestion it really talks about negative immunofluorescence. It doesn't talk about positive immunofluorescence. But when we were in Maui at the GlamCon conference, Jean Howard brought up the fact that occasionally she has seen cases where both kappa and lambda lit up, and then when they did pronase digestion, it isolated only one. And she had a name for it. I wrote it down. I fortunately lost it, but I'd always wondered about that, if that's the possibility. And so I think that number 2 kind of is the answer here. And in fact, in our poll, 3/4 of the people thought we should probably go ahead with pronase digestion. And maybe I led people on by my when in question pronase digestion. Maybe I should have kept my mouth shut. But indeed, that's what we did. And we don't do that. We sent it to Mayo. And lo and behold, at Mayo, kappa and lambda were totally equal, and they reread the whole biopsy with the immunofluorescence, and they felt it was compatible with a diagnosis of lupus nephritis.
So how often do you see big subendothelial deposits in these paraprotein related lesions? I mean, not to say that two things can't be going on at one time, but to see wire loops I mean, how, unless they've got cryoglobulinemia, and then it's really not wire loops.
Well, PGN-MID is an MPGN pathology, and I think that's totally fitting for that.
Really?
So I don't think that's out of the question. I mean, there's a lot of things that you know. Well, let me give it back to Bill. Tell us what fits, what doesn't fit, and how comfortable are you, Bill, and what would you do?
Well, it's not clean, as clean as we would have liked, but I think, you know, we've got some things that are pointing towards lupus. I know the absence of C1q is disturbing, but we've got, you know, wire loops. We've got tubular reticular inclusion structures. We've got segmental necrosis. You know, I think there's a lot there that can say it's from multiple different pathogenic genetic mechanisms. And, you know, lupus has that. Lupus has a lot of different pathogenic mechanisms that are not completely understood. So I think it's best is described as lupus, especially because the protease digestion was negative. And I would treat it like lupus, like active lupus nephritis.
Anybody feel differently? Dr. Rajasekaran, what would you do? What do you think's going on? What would you do?
So Roger, you know, I had PGN-MID on my differential right from the case presentation as potentially a red herring, but and I was concerned because the lambda was a little bit more intense. But if the pronase is negative, then it's really not PGN-MID. And agreeing to Bill and Steve's points about everything else, I think the other thing I wanted to mention was there's a CJSON article in 2019 on looking at the criteria for lupus and 5 criteria, including full house, intense C1q, subendo, subepithelial deposits, TRIs, and extraglomerular deposits. This patient didn't have full house, didn't have intense C1q, but met other 3 criteria. And just by these findings, and I would go more in favor of a proliferative lupus lesion.
Yeah, I hate those criteria. I mean,
Yeah.
I think they're for academics and things. I don't think they're real. You know, we've seen plenty of patients with lupus membranous that wouldn't qualify for lupus if you're strict by criteria. But I think, you think it's a lupus pathophysiology? Let's put it that way. Okay.
Yes.
Dick?
Roger, in the chat, there was a suggestion to do subclass IgG staining, which I think was a very good suggestion. Perhaps to have done before sending the biopsy to Mayo for pronase digestion. In lupus nephritis, obviously you'd see polyclonal subclass deposition. In PGMID, you should see monoclonal subclass, and that would be just as good a way to have made the differentiation as pronase digestion. I must admit, after the pronase digestion, PGMID really falls off the differential diagnosis. But still, I think doing subclass staining is something that can be done easily and locally and gives a pretty good answer.
David, can we do some IgG subclass, or do we have to, is that part of a send out?
Yeah, that's done at Mayo.
Yeah, did they do it? I mean,
No, they didn't do
they
it.
just did the pronase, okay. Yeah. Dr. Reen, how would you treat this patient?
Dr. Reen, you're muted.
No, I'm got unmuted. It looks like compatible with the lupus, proliferative lupus, so I think I'll go for that. That's what we have. That's what we have. I honestly thought it was endocarditis, to be honest with you, before the biopsy was reported, but I think we have to go with proliferative lupus.
Bill, how would you treat this patient?
Well, I think she's very frail. She has dementia. She has multiple cancers. I think that she's already on dialysis, although I know it's acute kidney injury. So I think
that's a really good point, because her I know that doesn't always correlate, but her creatinine is a lot worse than her biopsy.
Mm-hmm. Yeah, and I'm not sure. I know there's some interstitial nephritis there, but I'm not sure how much ATN was there. But you know, I still think there was enough there for glomerular lesion to be significant AKI. And I worry that immunosuppression may actually do harm here, at least aggressive immunosuppression. I would not favor the kitchen sink of cyclophosphamide and IV soluble and a ton of steroids and all that. I think that I would favor, a normal lupus lesion, I'd be happy to get because I would use CellCept, and then we're doing a study with Novartis for a complement inhibitor similar to what's been done in vasculitis. And so I would like to get people in the study for that, but she wouldn't qualify for several different reasons. I think something experimental here is not what we should do. So I think I would do CellCept, and I would start IV soluble initially because she's on dialysis anyway, and then go to 60 milligrams of prednisone, but I might do a little quicker of a taper just because I'm really worried about infection and doing more harm than help.
I think there is enough data, but Bill is pointing out fertility is an important issue, not to be very aggressive with this patient. Mild to mild type of CellCept and moderate doses of steroids, and 250 milligram of salumedrol for 3 days, and followed by 30 milligram, and then CellCept. And I will give her a month or two. If she doesn't improve, then discontinue it. But I think her fertility score is very high, so actually.
It sounds like from what Casey was saying in the beginning that he sort of simplified the case, but they were dealing with even whether to do the biopsy or not, and how aggressive are we going to be at pursuing things, or even start dialysis or not. And so I think it's going to be a tough decision that'll have to be made with the family and the patient, and really the physicians that are seeing her.
Yeah, I think that's a really good point. Sometimes, we just kind of, cookbook things and not look at the big picture. I think it's very wise. And, 30 or whatever prednisone for her might be a lot more for anybody anyway, given, her metabolism and everything. So I think it's a very wise decision. Casey, tell us your thoughts, and what do you actually think's going on, and what did you decide to do, and how's she doing?
So yeah, I mean, I did simplify the case for the sake of the biopsy conference, but we did have these discussions with the patient's family prior to the biopsy, and I talked to hematology, and I said, if I biopsy her and let's say I find a MGRS, is she a candidate for treatment? I wouldn't biopsy her if it's not going to change my management, and they said she would be, which I'm not sure if that's the case. I'm not sure if they would give her chemo, but it seems like when the biopsy first came out, it was read as MPGN, and the things that were odd about it, as everybody has mentioned, the lack of full house, the negative C1q, the fact that MPGN wasn't actually diffuse, it was some glomeruli did not have it, and the fact that the lambda was staining more strongly than the kappa. We were basically not really clear. So the initial report of the histology, the pathology report, wasn't really clear if this is lupus or PGN-MID. It wasn't until we sent for pronate digestion that Mayo definitively said, okay, there is nothing restrictive here, let's move on. And the EM, both the EM and the pronate digestion helped us sort of move the needle towards maybe lupus and away from paraprotein related lesion. So I opted to, as everybody mentioned, given her frailty and the fact that she's still on dialysis, I opted to put her on 500 twice a day of CellCept and keep her under 30 of prednisone. I basically half treated her, not being too aggressive because I didn't want to kill her from an infection, but I also didn't want to not treat. So I sort of took a middle road here. Not sure if that's correct or not, but that's what happened. She is doing okay. She's actually thriving a little bit better with the prednisone. She's on dialysis as well as she could be doing, and that's kind of where we are. I think that this has been 2 months post biopsy. I think I'm going to go for 1 more month, and if nothing is happening, I'm going to probably get her taper steroids and see if I can just lower her immunosuppression.
I'm surprised that she hasn't. Is she making urine?
Very little. She's oliguric.
I'm really surprised. I mean, that biopsy just seemed like there was reversibility. There wasn't much scarring. There wasn't much destruction. We had one segmental lesion. There was no crescents. I would have, typically give these patients, these are strong immune complex patients, a good response. Or prognosis. So I'm a little surprised she's not doing better. I think you're smart not to push it too far, but
This is probably the first case where I've had where the biopsy initially was raised more questions for me than answers.
interesting. Dr. Glassick, how would you treat her?
The same way that Bill did and JC, same way.
Anybody feel differently? I mean, about you know, should she been plexed, anything like that? I can't think of anything else. I think, you know, Bill's point about adding the complement inhibitor, you know, and that might be not safe for her, but let's say that let's just pretend, Bill, that she was younger, and I know your study probably doesn't allow you to start it after a month, but would you have wanted her in your study for this if she would have qualified?
Yeah, I mean, there's GFR cutoffs, et cetera. So she wanted to qualify based on that, but just this lesion itself, would it?
Yeah, that's what I mean, pathophysiologically.
Yeah, I think lupus is very, very complex, and if we're able to sort out sort of different class lesions or different effects later on, but I think you know, it's getting standard of care, so she wouldn't be suffering any different. It's just add on complement inhibitor, and you know, clearly her complement pathway is activated here. But I know that, I mean, that's sort of a generic answer. But and I have no idea if that works in lupus. That's why we're doing the trial, so we hope it does.
Yeah, I mean, it's certainly, you know, it's now being added onto vasculitis, and is your drug the target the same as avacopan?
No, it's a C3b inhibitor from Novartis, so it's a different, and avacopan is, I think, C3a, if I got that right. But there's a lot of different.
Avacopan is a
C5a.
C5a, I'm sorry.
C5a receptor antagonist, and iptacopan is a factor B inhibitor.
That's the one, factor B.
All right. Well, I don't know what to say. This was a really interesting and a tough case. A lot of opinions here, and a lot, like I said, a lot of red herrings. But I think the biopsy helped us quite a bit. Sometimes, you know, you biopsy someone with lupus, and you kind of already know, as Ed Lewis used to say, it's going to be bad lupus. But you know, there were so many odd things going on here. The question of cast nephropathy, the question of PGN-MID or some other paraproteinemia lesion. I mean, we're still left with what looked like a drug-induced lupus, at least with the antihistone antibody and some of the serology, but no drug to explain it, and also the lack of full house. But I think in the end, you have to consider an immune complex glomerulonephritis that's as close to lupus as anything, and I think we treat it. That's what Casey felt and was treating it as such, and I think it's a great decision. Let's just hope she can get off dialysis soon, although it's not looking great given the length that she's been on it. Let's wrap this up. We have some. This is interview season, so we've got some residents interviewing for fellowship. I should have welcomed them initially when we started, but we're glad to welcome them, and we'll get on with interview season. I think next week we're off because the local National Kidney Foundation has what's called citywide rounds, and that's a clinical case that we'll be doing kind of similar to the way we run this. So I think we'll be off next week. We'll let you know either way, one way or the other. And Dr. Reen, let's work together so that we can kind of time our biopsy conferences together. Thank you. Thanks, everybody. Great case, fantastic case, great discussion. This is one of my favorites for a while. So we'll see everybody whenever. And until then, stay safe.